just stand here and yell, if that's okay with you guys. I want to thank you for spending a Tuesday night with me instead of with your family and friends and loved ones. Chances are many of you in the audience would know someone suffering from osteoarthritis of the hip. And if you know that person, you know they often suffer from debilitating pain, both during the day and at night, and often have to adjust their activities during the day in order to minimise their pain levels. Thankfully, total hip replacement, as you can see on the right, is a successful procedure at minimising or at least eliminating pain in patients with osteoarthritis of the hip. However, we need to think of this procedure as more than just a pain relief exercise, particularly because there's still a proportion of patients where the stability of the components are compromised and leading to earlier failure of the implant, as you can see on the left here. The acetabular cup, which is one component that goes into the pelvis, has migrated and angled downwards, and that would often result in revision hip replacement, which often comes with more cost and more complications such as infections. It's postulated that there's many things that can affect or increase the risk of someone's failure risk. One is the individual anatomical variances that we all have. The second is correct alignment of the prosthesis during surgery. And the third is the mechanical loads that we have at our hip joint during day-to-day activities. Take, for example, the prosthesis alignment in the middle. The patient is typically placed on the side for a posterior surgical approach, and that alignment or that position of the patient allows for optimal alignment when the surgeon's doing their work. However, we know that the force that the surgeon has to apply into the acetabulum in order to get proper fixation of the prosthesis will move that patient out of that alignment position, and sometimes up to 10 to 15 degrees, and that can affect the alignment of the prosthesis during surgery. We can understand the anatomical variances and the surgical alignment using medical imaging techniques, but it's more challenging to understand the effect of the mechanical load on implant stability, particularly when we're talking about internal hip joint loads following joint replacement. So how do we measure these joint loads at the hip? Well, one technique is to use an instrumented prosthesis, as you can see on the left. However, the feasibility of this is questioned, particularly because we don't know the survival of this compared to the current clinical implants that are used in surgery. The second approach is to use musculoskeletal models where we simulate human movement and predict the joint contact loads that are happening during our day-to-day activities. But of course, if we're going to use musculoskeletal models, we need to be sure that they accurately capture the anatomical variances and the geometry changes during surgery in order to predict these joint contact loads. If we can have a musculoskeletal model that captures those things, we can find the optimal combination of anatomy, geometry variances in surgery, and forces after surgery to get the optimal stability of the prosthesis. So giving you a quick overview of how these musculoskeletal models work, we typically start with external markers on the left that you can see in yellow that we put on the skin of individuals in, let's say, a gait laboratory. We have corresponding markers that we put on a generic musculoskeletal model in a computer software, and essentially take the ratio of the differences between these markers in order to scale the musculoskeletal in both length and width in order to match the individual. We can improve these techniques by using functional methods where we ask the patient to do a series of movements with their hip, and that will predict the hip joint centre, or we could use mathematical regression techniques to predict the joint centre. And the importance of predicting the joint centre is that not only helps with the scaling process, but also it affects the muscle moment arms, which then predict the joint contact forces later down the track. In the perfect world, that would accurately capture the anatomical variances of our individual. However, the practical problem is that we often end up with this really large pelvis sitting on top of normal-sized femurs and tibias, which are thighs. This problem is compounded, and I want to be politically correct, this problem is compounded when there's increased soft tissue padding between the underlying bone structures and the external landmarks that we have. We end up with this really big pelvis. And there's an example of one of the patients from the Royal Adelaide Hospital that we have, where the point cloud is how big the model thinks the pelvis is compared to the actual CT, which is in that bone colour. And we can see that there's 5 centimetre differences in height and up to 10 centimetres differences in depth, not so much in width, however. So if we're going to use these models, we need to do better than just this. My solution to this problem has not been to use a linear scaling method, but what we call an atlas-based scaling method using statistical shape modelling. The way this works is we start with our markers as we did in step 1 in the previous step. But instead of doing the linear scaling approach, we interrogate a database that's filled with lower limb bones and their articulated shape models from cadaveric specimens. And we've got up to thousands of them.
Thank you very much. Any questions from the panel?
Let them start this time. No questions.